This is our second one this week, actually. Today we have Catherine Moore. We're super excited you could join us today. Thanks for being here. My name is Adam Hoffman, and I'll be your moderator today. For those of you who are new to Singularity University, our mission is to educate, inspire, and empower leaders to apply exponential technologies to address humanity's grand challenges. We do this through both in-person as well as digital programs, projects, and events around the world. With these webcasts, we're bringing experts from the SU community directly to you to present on a variety of topics across all the different domains that we talk about here. Some of our upcoming topics include reducing the threat of nuclear weapons, the future of sports, as well as the future of work. I see everybody introducing themselves. Welcome, thanks for joining us today. Let me show you a little bit around Livestorm. If you're new today, that's the platform that we're using. So if you look over on the right, you'll see chat, questions, and polls. Looks like you found your way to the chat. Feel free to send each other messages. People like to drop in LinkedIn profiles if you're looking to connect with one another on this topic. We're also going to be using polls throughout the session. So that's when we get to ask you guys questions. We'd love for you to respond. And then, of course, we have the questions tab. So if you have something you want me to ask Catherine at the end of the session, go ahead and ask it in there. And then, of course, upvote your favorite, and we'll take the most popular ones at the end. Also, we're curious, if you've been to more than 4 of these webcasts, so you've attended 4 of these, basically more than just a couple, and are open to giving us some feedback about some new ideas we're throwing around, we'd love to talk to you. Send us an email, digital@su.org. I think Sveta will drop this in the chat with the subject of EOA, Experts on Air Feedback, and we'd love to set up a conversation. So back to the session today. Today we're going to focus on why you should expect your future surgeon to be a robot. And just a little heads up, I have seen the slides. Some of them make you squirm a little bit, so they're a little graphic, so heads up there just in case. And with that, let me tell you a little bit about our guest, Catherine. So Dr. Catherine Moore is an expert in the field of robotic surgery and sustainable technologies. She holds patents for medical devices, has been involved with several startup companies. Today is the Senior Director of Medical Research for Intuitive Surgical. They make the Vinci robotic surgical system. She holds a medical degree plus degrees in mechanical engineering, and has worked in the fields of alternative energy and transportation, including alternative energy vehicles and sustainable tech. During her initial training as a mechanical engineer at MIT AI Laboratory, pretty rad, she developed compliant robotic hands designed to work in unstructured and dynamic environments. Later, while pursuing an MD degree at Stanford, she identified needs for new laparoscopic surgical instruments and collaborated to develop the first totally robotic, I don't know how to say that.
Gastric bypass.
Just that. And invented and then started a company to commercialize the LapCap device for safely establishing. Oh, another big word. Man, I should have practiced this more. Anyways, we are so excited to have you today, Catherine, and I will turn it over to you.
All right, thank you very much. And that last word would be pneumoperitoneum, and it means inflating the abdomen with gas.
I'll be saying that all night.
Yeah, well, every specialty has its own jargon. And so I'm going to try not to be too jargony on this one. Thank you for joining us on the future of robotics and surgery. I'm going to be talking a little bit about a lot of the technologies that we put onto the platform and a bit about the robot itself, but would encourage questions in pretty much any area that you've got about this. But before I talk about the future, I'm actually going to talk about the past a little bit. I'm going to give you a little bit of an idea of the context. And this is because at Singularity, a lot of the things that we're looking at is how rapidly things change. And so if we go back about 100 years ago, this is 1916, and you can see along the bottom, it's income per person per year, GDP per capita. And up on the left-hand side, life expectancy in years. And so what's interesting about this is that you can see that you can draw a line through the middle of your data like we all like to do. And that gives you an idea of, in 1916, how much healthier you got as you got wealthier. So as a country had more GDP per capita, its life expectancy went up, and that's a pretty constant relationship. But you'll also notice that there's almost no countries that are above a 50-year life expectancy. The United States and some of the European countries, the green dot above the line is the US, are outliers on that. But a lot of Asia Pacific, which you see in red, or Africa, which you see in blue, is down in the 30 average year life expectancy. And you see Europe spread out in the 40s, but still very few above 50. Now we can play this. Oh, we can play this. Is it playing as a video? No, the video isn't working. Oh, we should have tested that before. Anyway, well, so we have a problem with the video. Let me describe to you what would be going on with this video. As it's playing forward, you see the movement of all of these dots. And what's fascinating about it, and we'll see if we can gather this for towards the end and show it during the Q&A, is that you see large motions in the world's population in terms of life expectancy. But after World War II, there's an enormous acceleration of all of these dots up above that 50-year life expectancy line. And when we get to modern days, you'll see that that line has both flattened out, and all of the data would be sitting on that line, and there are almost no countries left in the world that have a life expectancy of below 50. Now that's an enormous change that happened in 100 years. And if you had looked at similar data for the 100 years prior to that, you would see that there had been very, very little motion. Everything had moved along that line of life expectancy as a function of wealth. But what we saw in the last 100 years was an enormous acceleration. Even the poorest countries, which have not moved in real terms, in terms of income per person, had moved up above that 50-year life expectancy line. And so the fundamental changes that happened in these last 100 years are all about technology. And one of the main technologies that we got is vaccinations. So vaccinations were first being licensed in the early 1914, and they weren't really in widespread use until about the 50s. And then we saw the rise of antibiotics, which came out in World War II, and all sorts of pharma to treat other kinds of chronic diseases. We also saw an enormous change in surgery. And I probably shouldn't have sprung that one on you without a little bit of warning, but this is what surgery looked like for most of those 100 years, where we would make a big incision in the body, we would be able to put our hands inside, we would be able to look inside, and we would be able to take out a tumor or modify the body in some way that would then allow that body to heal. But it comes at a cost. You put a big incision in order to be able to get your hands and your eyes inside. In the late 1980s and early 1990s, we saw the rise of laparoscopy. And this is a fascinating technological advance because it didn't come out of medicine in a lot of ways. Laparoscopy had been around for almost 100 years, but what caused this big jump in the use of laparoscopy actually came out of microelectronics. Small sensors and small cameras that could get put onto a rod lens allowed suddenly everybody in the operating room to be able to see what was going on inside the body. Prior to that, it had all been direct observation. And that change in an adjacent field caused a revolution in the field of surgery. Now, laparoscopy took off in a lot of areas where it was relatively simple surgeries, but for very complex surgeries, like a lot of the ones that I showed you in that previous picture, laparoscopy didn't gain widespread traction. And I'm going to give you a little demonstration. If you've got a pen in your hand, or a pencil, or anything like that you can pick up, if you think about using a long instrument through a body wall and being able to do surgery on the other side of that body wall, if I want the tip of that instrument to go right, my hand goes left. If I want it to go left, my hand goes right. Up is down and down is up. If it's a pen or a pencil, try writing your name on the opposite side as everything runs backwards. It's quite possible to learn how to do, but it's difficult. And what that ended up meaning is that there was a sort of a natural ceiling to how many different kinds of procedures were being done laparoscopically. So even though the real value was taking that large incision and turning it into a small one, few Band-Aids on the belly, the penetration of minimally invasive surgery in much more complicated procedures was actually quite low. And so robotic technology was brought in order to sort of bridge that gap between what we wanted to be able to do for the patient and what we could do for the patient. And so this is the business end of the Da Vinci surgical robot. It is the wrist. It's taking that pen and essentially grabbing it virtually at the tip of the pen and being able to use your fingers and use your wrists in order to do all of the motions that you would be doing inside that body, but still through very small incisions. And what this means is that you can do surgery on the inside of the heart, like here, repairing a mitral valve, without having to crack open the chest. You can do it through these small incisions. And so since its introduction in the late 1990s, early 2000s, there are now over 4,000 of these installed worldwide, and they're spread all over the world. The real goal for all of this, and the framework that I'm going to use to talk about some of the technologies that are going on to robotics, is really advancing minimally invasive surgery, trying to bridge that gap between places where minimally invasive surgery was being applied and all of the potential places that it could be applied. And so bringing technology, smart application of technology into that, with the overall goals of faster recovery for the patient, faster return to productivity, and overall quality of life. That's the motivation for bringing this technology in. But the technology also isn't monolithic. It's made up of several different kinds of technologies. And so I'll break it down and I'll focus on those individually. So the first one is really enabling less invasive approaches, the big idea of getting to that small incision. And so this is what the Da Vinci robot looks like now. Early on in its incarnation, it was a little cruder looking than this, but this is designed to be able to pivot above the patient and be able to be used in any quadrant of the abdomen. The surgeon sits at the console. They see a 3D image through the scope into the patient, and they are manipulating those controllers that you saw in the video that are then driving the motion of the instruments that are inside the patient. The next incarnation, so these aren't out yet, but this is coming out in the not too distant future, are instruments that come in parallel. So it's a cluster of instruments that can go through a single incision. And so these ones come into the body, and unlike the laparoscopic instruments that are all brought in, or the multi-port robotic instruments that are brought in and converged on a certain point, these come in parallel, they come out, and then they converge back towards the point at which you would be working. And so this allows you to then go from multiple incisions to a single incision. But sometimes even that single incision doesn't have all of the capabilities that you really want it to have. In the case of lung cancer, you can come in between the ribs and you can biopsy what you suspect might be a cancerous tumor. But when you've done that, you've gone through essentially the wall of the lung called the pleura. And by going through that, you've put a hole in sort of the layer that keeps the air inside, the integrity of keeping the lung inflated. And often patients, when they're getting a biopsy to tell whether something is a cancerous tumor, is the result is that they end up getting a deflation of that lung, and they end up having to get a chest tube and staying in the hospital overnight. And so what we really want to be able to do is get it from the inside. But being able to go all the way through all of those tortuous, windy pathways to get all the way out to the edge of the lung where a tumor might be, you need something flexible that can navigate through the lung and also be able to do something clinically useful when you get there, and recognize that you are distorting the lung by the very fact of putting something through it. So you've taken an image of where that person is in a CT scanner, and you've figured out where that nodule is that you'd like to biopsy, but the very act of putting a catheter down through the lung will change the shape of the lung and move where that tumor is with respect to the outside of the body. And so, again, taking this kind of technology, you can bring in a flexible robot, a long catheter-based robot that can measure the shape. We have a sensor that determines sort of the pose and the orientation and the path that that catheter has taken. And you can find your way down through all of those pathways, like following a roadmap, and get to where that tumor is. And then with the stability being able to be brought by controlling the catheter robotically, a biopsy from the middle and a range of biopsies from around the outside. So why would this be something that we would want to be focusing on? I'm using lung cancer survival data here from a Chinese registry. And I'm using the Chinese registry because China has a particularly high incidence of lung cancer and is on a path to have over 1 million lung cancer deaths per year starting in a few years from now, and its rate is slowly approaching that. And this is a terrifying prospect in terms of that many people with lung cancer. And one of the important things to understand is that lung cancer is one of the deadliest cancers that we have. I've drawn a line here through 5 years. This represents 5 years after diagnosis. And in this graph, what you see is cumulative survival. What's the likelihood that you're still alive after 5 years if you were diagnosed with lung cancer on year 0? If you're found with stage 1A, that's a tumor about this big and no extension beyond, you have about an 80% chance of still being alive at 5 years. That gets progressively worse as the tumor gets larger, as it spreads locally, as it crosses over from one side to the other, and as you get distant metastases. The bottom line on this, the red line, is stage 3B. That's still confined to the lungs, but it has cancer on the other side, the other lung. Globally, the average 5-year survival after lung cancer diagnosis is 15%. That's because it's generally not found until there's already metastases well outside the lungs. And that graph isn't even on this. It drops off so precipitously. The thing is, at 1A, the small tumor size, 9 out of 10 nodules in the lung of that size are benign. And if you go in and do surgery on 10 people to find only 1 cancer, you'll kill more people than you save. And so being able to go in without causing morbidity associated with deflating the lung or having to do surgery, and being able to definitively diagnose and treat that, is this place where we've got this gap between what we want to be able to do for the patient and what we can do for the patient that we can fill with this kind of technology. So that's just one area where we think about the size of the approach, the circuitous nature of the approach, the way in which we come in, changing the way we get into the body. We also want to change the nature of what we do when we get there. And so in order to be able to do that, we have been bringing enhanced imaging onto these robotic platforms. These are essentially ways in which we can have the surgeons see things that they would not otherwise be able to see. We see reflected white light. Everything is a color. As a optics friend of mine likes to say, color is a pigment of your imagination. It doesn't actually exist. It's a spectrum, and our eyes squash it together and think of it as a color. It's also very limited in that we can only see from down in the blues up to the reds, but ultraviolet and near infrared aren't visible to our eye. They are, by definition, outside of the visible spectrum. But cameras can see in those wavelengths. And because of that, they can also see spectrum, which our eyes can't see. And there's an enormous amount of clinical information that's available to us in the wavelengths and the spectrum that cameras can see that aren't available to the naked eye. And so another surgical image, probably should have warned you a little earlier than that. This is a kidney. And these are the blood vessels that run into a kidney. If we want to take only a portion of that kidney, the portion that has a tumor in it, we would like to be able to cut off the blood supply to that portion of the tumor and then remove to that portion of the kidney and then remove all of the kidney that is fed by that blood supply and no more, because that will get us the least amount of bleeding and have the most amount of viable kidney still left for that patient. We can use a dye called indocyanine green, which fluoresces in the near infrared, one of the wavelengths that our eye is not sensitive to. But it passes through tissue extremely well. So we can see deep into the tissue when things are fluorescing in near infrared. We can make the blood glow in near infrared, and we can see if we were to clamp off one of those blood vessels that a portion of that kidney now is dark. It doesn't get the fluorescence in it. And we can demarcate where we're going to cut on the kidney. We can also use fluorescent dyes to look at other structures within the body. And so what we have in the upper left is, and the upper right actually, are both the ureter. So this is the channel that runs from the kidney down to the bladder, and it is mistakenly cut in surgeries more often than anyone would really like to have happen, because it can result in the loss of a kidney if it's undetected. And so being able to see exactly where that runs in the body and to be able to avoid it is essential. In the bottom left, you see the dissection around a gallbladder for a cholecystectomy or a gallbladder surgery. And in this particular case, the surgeon wants to cut the cystic duct, absolutely needs to leave the common bile duct in place. And in this case, there was an extra little duct that stuck out of the cystic duct. In a lot of surgeries, if this wasn't detected, and it often isn't, it can lead to a bile leak. It can lead to chronic leakage into the abdomen and another surgery for that patient. Or if the common bile duct is cut by mistake, mistaking it for the cystic duct, that patient, again, if it's undetected, can end up on the liver transplant list because the backup of bile can destroy the liver. In the bottom right, it is being able to find the sentinel node, the first lymph node that drains out of a tumor, and being able to tell whether there is cancer in that node, being able to take it out and section it, and know that if there is no cancer in that node, likely your treatment can stop at that point for that patient. You don't need to give them radiation, you don't need to give them chemotherapy, you don't need to take out all the rest of their nodes. All of these things are about improving the clinical decision-making on the part of the surgeon so that they don't end up with bad outcomes, with errors. We can also add in different kinds of ways to see into the body. The windows that you see on the right are confocal microscopes. Those are images that are about 200 microns or 250 microns across. And so we're looking at blood vessels, we're looking at nerves, we're looking at the blood supply there in those tissues that are being measured. On the left, you can see an ultrasound probe. All of these are separate technologies that aren't made by a robot company per se, but can be put onto this platform and integrated into the platform so that you can give that surgeon better clinical decision-making capability. This is taking a 3D reconstruction using a CT scan, windowing it so that you can see just the blood vessels. This is for the particular patient, and intraoperatively being able to overlay the 3D image of that patient's vasculature onto their kidney. So being able to give, like I showed in the lung situation, real-time navigation to the surgeon on where it is they need to be going and seeing structures below the surface that wouldn't be visible to the camera initially. So the common theme in all of this is that we're turning what had been something that was directly observed by the surgeon, either touched or seen, we're turning it into data. It's a digital intermediary. We've taken a controller and we've measured the position of their hand, and we've recreated that motion in an instrument that's inside the body. We've taken an image that they would otherwise be seeing, and we've captured it with a camera, and then we've represented it to their eye. When we take essentially what is taught as an apprenticeship model, what's a directly observed thing, and we turn it into data, we start to be able to put data analytic envelope on that. We start to be able to use data techniques to understand it. And so this leads to being able to add intelligent systems onto a robot. And at its simplest, one of our intelligent systems is what we call smart clamps. So this is a surgical stapler. And how they work is you close those jaws over tissue, and an anvil comes along and shoves staples from one side to the other and has a blade that comes along after it. And so the two sides are stapled and divided, and they're sealed off, and now it's been cut and sealed at the same time. If you have a mismatch between the length of the staple and the thickness of the tissue that's going through, you're either going to squash that tissue too much, or it's going to be too loose and it's going to leak. And squashing it too much means it dies and it leaks, and too loose means it leaks. Both problems. You need the Goldilocks zone of the staples. You want it to be the exact right length for the tissue that you've got. With being able to measure these sorts of things, you can look at or measure the thickness of the tissue, know the length of staple that you've got in that cartridge, and be able to guide, do I have the right kind of staple? The other kinds of things that we can do, so this may seem like a not very surgical image, but this is actually image recognition that's being done. Another way in which we can turn this sort of digital data stream or digital stream of information into data. This is of huge interest in a lot of adjacent fields where people are trying to be able to recognize faces or images in both video and in still. And so what might recognize faces in the most star-studded selfie ever can also be used to look at still images from video in surgery and be able to recognize what stage of the surgery you're in, is it going well, and be able to predict what you might want to do next. This is critical information for being able to give situational information. And so this is real data from our lab on looking at a standardized training test where we were using image recognition to try to figure out what stage of the training test they were working on, and 5 different algorithms running along the bottom. So you can see that they don't agree perfectly, but that there's sort of a general move towards being able to recognize which portion is which. It's improved enormously since this data, and I need to update this slide because it actually looks a whole lot more like they're in full agreement. And the key thing is we don't have to develop this ourselves. There's a huge amount of work being done in all kinds of adjacent fields that are looking at improving these tools. And medicine today can, like pulling the microprocessor over and the camera over to allow the laparoscopic revolution, being able to pull these machine learning techniques over and these image recognition techniques over is allowing a huge amount of work to be done in image recognition within medicine. Because frankly, a lot of medicine is pattern matching. And understanding how we bring all of these things together is really critical. Another way in which we think about robotics and robotic platforms is not just as data inside them and the way in which we're supporting clinical decision making, but also where does it sit in this larger field of data analytics, and how does it fit with the systems within the hospital and how a hospital is managing its own data. And so this gets into the world of larger data analytics as we're trying to improve outcomes in medicine and really understand how all of this fits together. And so this is a bit of a busy slide. The point of it is this is the kind of data that we will help hospitals with when they're trying to figure out what's the impact of bringing this sort of technology into their hospital. So this is a hospital's actual data looking at when they started doing colon cancer surgery with robotics, how did it change their outcomes associated with robotic, with laparoscopic, and with open. And what you'll notice, and this is one of the key things, is that whenever you bring a technology in like this, it doesn't actually replace all of the way that people were doing it before. It comes in and it becomes part of the practice of medicine. But they wanted to know, should we be shifting it one way or the other? And the answer was, well, with laparoscopy, they got much higher conversion rates. So 23% of people thought they were getting a minimally invasive surgery. And then when they woke up after surgery, they discovered it had been converted to an open surgery. And that those rates were much lower if they went robotic. Surgical site infections were much higher, and the readmission rate was higher, mostly in the open surgeries. And so this is a way in which healthcare systems, whether they're an American single hospital or the NHS or an IDN system in Germany, can figure out what's the impact of bringing this kind of technology into their hospital. And last but certainly not least, when we think about how this technology interacts with the world at large, it's about the training of surgeons and the use of this tool by those surgeons. And so the last thing we get to do with digitization is really think about how we bring training into the operating room. So Intuitive runs training centers all over the world, essentially placed where there is the highest density of surgeons that need training, and they're going to come and do a day-long training in a simulated operating room. But not every surgeon is there, and not everyone can make that kind of a trip. If we can bring the training onto the robot itself, so the tool teaches you how to use it, then you've brought it in real time so that people can improve their skills while they're going along. And so you can take simulations of surgeries, we can watch how people do and the kinds of mistakes they make, and tailor the sort of exercises that we would have them do to the kinds of mistakes that they're making. And so we can look at not just see one, do one, teach one, but can we take people along a mastery curve by really truly observing what it is that they know how to do and tailoring what they're going to do for that. And so we also have remote cameras that we can put in the operating room so that people can mentor across a distance. But overall, what all of these things are is technologies that sit on a robotic platform that allow the surgeons to make better decisions, be able to train one another, do peer-to-peer training, and overall be able to figure out how this fits into their practice of medicine. And so these are the kind of the building block technologies that end up allowing us to really advance the minimally invasive surgery. I don't have my last slide checked, but there we go. And so with that, I think we can turn it to questions.
Thank you, Catherine. That was I'm really impressed with how much you got into that period of time going over such complex topics, and I didn't feel like anything was like too. I mean, I don't really know anything about this stuff at all, to be totally honest. But everything felt I could understand. I could take it in. I felt myself asking questions. So thank you so much for delivering that for us today.
Well, and for each one of those subjects, catch me alone over a glass of wine, and I can talk hours about each one because there's so many things that go into each one of these. But yeah, it's an exciting time to be thinking about these platform technologies. Absolutely.
All right, we've got some great questions that I'm going to dig into here in a second. I might have missed this, so please call me out if I did. But what percentage of surgeries right now are open, robotic, lap? Like what does that breakdown look like? Do we have any idea?
We do. It varies by type of procedure, and it varies by geography. Okay. Because so in the United States, about 90% of prostate cancer surgery is done with the Da Vinci. That's and in Europe, well, if we consider the UK, still part of Europe, I guess still pre-Brexit, where it's still Europe. It's like 95%. It's even higher than the United States. Whereas in France and in Germany, the percentages are down in the 30s, or actually I think maybe getting more up to about 50%. And in Asia, in China, which is enormous, and it's a vanishingly small fraction, even though China is our third largest market. It's just because there's so many people in China, it has this enormous denominator. So that's prostate cancer. The next highest adopted procedure is in cancer hysterectomies, and those tend to be in the 70%, but in some parts of the world, it's 5%, 0%. And then general surgery has been growing at the fastest pace. Those are the lung cancer surgeries, those are the gastric surgeries, those are colon cancer surgeries. And that's changing so rapidly, I think my numbers are out of date.
Fair enough.
So yeah, but those are in the 20s. They're growing. It needed a new robot, essentially, to be able to do colon cancer surgery, because the older robots wanted to be able to work just in one space, and the newer robot pivot during the operation and in multiple parts of the abdomen.
Got it. Another question. So you were kind of talking about being able to do these trainings around the world, and I immediately imagined you've got all this technology sitting in the operating room, and the operator is obviously somewhere else, even if it's the room next door. How does latency and connectivity impact the usage of these platforms?
So we have a fiber optic cable that runs between the console where the surgeon is sitting and the robot itself. And so even if they're sitting in the room next door, it's vanishingly small latency.
Got it.
It's theoretically possible to do surgeries at a larger distance. You get above more than 200 milliseconds of latency, which you can get on a network just like that. You start to have real problems in terms of precision and the surgeon being able to operate. But this begs the question, which may or may not be in your sets of questions as well, people doing this remotely.
That's what I'm sitting here wondering.
Yes, well, and that's the question that it was. A lot of the early technology was intended to be for remote surgery, but when you want to do remote surgery, what you're really trying to do is you have a mismatch. You've got expertise in one place and you've got need in another place, and you want to bridge that geographical distance by telesurgery, bringing expertise to the need. Where you have the patient, you still have the need for an anesthesiologist, you still have the need for someone to be able to support that patient around, so you need at least a rudimentary surgical team to support that patient at the site where the need is. And I would argue that what you really want to do is you want to do telementoring. You want to teach at a distance. You want to have the expert walk a more junior surgeon through the procedure at the site where the need is. And then you've done two things. You've addressed the need of the patient. You've trained someone there, so you've actually increased the overall capability over here. You haven't further centralized expertise. And most of the places where you have this kind of need, you don't have super high bandwidth internet connections.
Mm-hmm.
And so that mismatch of both delay and the potential that if the link goes down and this person is responsible for their life, that's kind of not the right structure. So I think everything goes in the right direction if we think about it as telementoring. If we think about peer-to-peer mentoring and using this as a platform where the surgeons can communicate over vast distances. Now, that being said, you can do it, but it generally only gets done within a closed healthcare system where they understand all of the medical legal and they've got all of that sorted out. I think for real addressing this global mismatch of need and expertise, it will be telementoring and teleproctoring for a long time.
Okay. So we have a lot of questions about predictions, and you know we're at Singularity University, so we got to make some predictions, or at least creatively dance around them. I think that most people ask generally about the shift from, so we're talking about pretty big robots here, right? Mm-hmm. When do we start thinking about these nanobots that are, floating around in our bodies and constantly repairing us? What is that timeline to the transition from big external robots to tiny internal robots look like in your mind?
Well, so there are a couple of technologies that have to happen and are on exponential curves. One is energy storage, and the other is information density. So being able to make something smart enough to be able to work autonomously in the body, when we aren't currently smart enough to make the big robots work autonomously on the outside of the body. So we've got two problems. One's the autonomy problem, and then the second one is a big, taking Deep Blue or whatever that big, computational engine ends up being, and being able to miniaturize it. So you never say never. Everything is moving at these really fast paces, but you have an energy problem and you have an information density problem coupled with the autonomy problem, all of which we're on pathways to solve. The one thing we're not yet on a pathway to solve, and this is where linear comes and bites you in the butt when you're counting on exponential, is in material properties. And being able to make something strong enough that it can be an actuator that can, not all surgery can be done on this micro scale. You need to be able to retract something to be able to cut it. There are fundamental length scales in some of the things that we're talking about. And the materials and their capability to do force is actually on more of a linear than on these exponential curves. And that, in the long run, may end up being the limiting factor on it. That said, you can keep a lot of smarts outside the body, and you can put a lot of force down a catheter. And so while you haven't dropped an autonomous robot into a body, you can do a super small incision, not a big robot, but one of these catheters, and be able to do a lot of very useful things on the end of that catheter. And then all you need to solve is the exponential problems, the information, the autonomy, but we have a lot of steps between here and there that are absolutely useful. And so we'll be making those tools all the way along.
Yeah, I think that's a fair answer. I'll accept that one, and we'll go too much deeper.
Dance around predictions.
Well, I think people are always like, "Oh, it's going to happen in 50 years," and you're like, "I'm not going to get into that." And this is the nature of exponentials. If you're off just a little bit, you're off by a lot as soon as it gets out there. So time predictions. Was it hard to make predictions about, especially about the future? But you can see technology pathways, and you can see a set of possible futures, and then you can say, what are the indicators that are telling us which one of those futures is coming true? And they're, depending on which technologies get better faster, we will have a different pathway through this set of potential futures that kind of diverge from here. And so being in the world of trying to make predictions, this is I tend to think along the lines of predict the range of the possible and then figure out as you're going along which ones are coming true. Yep, right on. I think this is more of a practical one that a lot of people are wondering about. What are the costs compared to non-robotic surgeries? We kind of talked about this a little bit earlier.
Yeah. So this is it all depends on where you draw the bubble. So if you were to say, I'm going to draw a box around my operating room, and in that operating room, I'm going to measure all of the cost of the instruments and the robot and all of that sort of thing. The robot will always be more expensive than most some laparoscopic procedures will be more expensive because of the use of disposables, but in most cases, the robot will be more expensive than open or laparoscopic. If you extend that bubble to the entire length of stay of that patient, and you look at how long they had to stay in the how long they had to stay in the hospital, the average effective complications associated with that, all of that sort of thing. In most cases, robotics ends up being cheaper than open, and in a lot of cases, it ends up being cheaper than laparoscopy. If you then extend it to overall as a society, how long did it take for that person to go back to work and to be productive again? So if you're Sweden, you look at, because the same group that pays for your hospitalization is paying for your time off work. So you're here in US, the company pays for your time off work, but there it's sort of part of the healthcare system. And they looked at it and said, oh, after minimally invasive surgery, people go back to work after 11 days. After open surgery, they go back after 7 weeks. The difference in cost to society of that,
yes, huge,
so overwhelms everything that you see inside the operating room. So the answer to what costs more is so dependent on where you draw the boundary on what it is that you're trying to measure the cost on. And the healthcare system within which you're working, and interestingly enough, there are several ways of cutting the data where you look at it, and we didn't understand why it was taking off in a part of India, because we would think if ever there was a cost-sensitive market, it would be India. Well, it turns out, the whole family relocates to where the hospital was, and being able to be discharged and to go home and not have all the cost of the whole family being in a city for a while in the recovery period, it made sense, and they're paying out of pocket. So this was, we've seen interesting ways where you dig into the economics and you get some non-intuitive results.
And with that,
no, I was sort of like, how do I change that sentence halfway through saying it? And then I didn't.
That works. We are at our 45 minutes for today. So Catherine, thank you so much for joining us.
Thank you.
I really enjoyed this. It was great to have you today. And thank you everybody who tuned in. We got to as many questions as we could. We'll try to get some bonus questions answered maybe afterwards and post those. We've got a link here. We'd love your feedback, what you thought of the session. We're always trying to make things better. So please fill that out. We also are going to be putting this replay as well as some bonus add-ons in a new part of the website that we're launching soon. So request and access to what's called Experts on Air Premium up above. And then, of course, we have some great sessions coming up. We're going to be talking about nuclear threats next week. So if you've paid attention to anything in the news recently, you might want to tune into this one and see how this organization N Squared thinks about nuclear threats. So thanks everybody for joining us. Thank you so much, Catherine, and we will see you guys next week.
Thanks.